Uh, I, on behalf of Department of Rheumatology, welcome you all to this clinical combined round. Going with the round, today we are here to present in front of you a very interesting case which has actually puzzled us, and still we don't know whether you are going to be convinced by the diagnosis we made. So for that, today Dr. Danvi Bhalu, who is the addition professor in the department, is going to moderate the case. And Simar, who is a bright young JR in our department, representing the case, and discussion will be by Dr. Sanjay, who happens to be the senior resident in our department. Over to you, Dr. Danvi.
Thank you. Good afternoon, everyone. And the radiology part will be discussed by Dr. Neha SR from radiodiagnosis, and Dr. Hemant from the nuclear medicine will discuss the nuclear medicine. So now I would like to request Dr. Simar to present the case.
So starting with the patient details, our patient is a 33-year-old female homemaker resident of Delhi with no known comorbidities. In the background history, the patient was diagnosed with hyperthyroidism in 2019, for which she took antithyroid medications for around 1.5 months, developed hypothyroidism subsequently, so the medications were stopped, and on subsequent thyroid profiles, there was euthyroidism. So when she presented, she was not taking any thyroid medications. She also had cholecystectomy done in 2021 in view of acute cholecystitis. So her first episode happened in February 2024 when she was admitted in Max Hospital with complaints of sudden onset of vomiting, multiple episodes, contained food particles, bilious, and there was no hematemesis. The patient also had loose stools with stool frequency of 2 to 3 episodes per day, watery in consistency, small volume, and there was no history of any obstipation. She also had pain abdomen in the lower region, which was colic in nature, and there was no history of similar episodes in the past. On investigation, upper GI endoscopy was done, and esophageal stomach biopsy showed some non-specific inflammation. For the entire year subsequently, she was asymptomatic. For the treatment part, she was given IV fluids, IV antibiotics, and IV analgesics, but there was no response to IV antibiotics. The patient was given IV steroids for 5 days, followed by maintenance on oral steroids, and she had good relief on oral steroids. But there was no confirmatory diagnosis made during the first episode. Subsequently, for the entire year, she was asymptomatic, and the second episode happened in January 2025 this year, when she was again admitted at Max Hospital with similar episodes of vomiting and pain abdomen. There was no loose stools this time, there was no obstipation, and NG tube was placed, as you can see in the image. All the routine investigations were normal. IgA, TTG levels were done, which were negative, and CCT abdomen was done in this episode, which showed hepatomegaly and moderate ascites. So cycle tap was done, and that showed high SARC and high protein ascites. For the treatment, she was again given IV fluids, analgesics, and IV antibiotics, but she did not respond, so given IV steroids, followed by oral steroids. And again, no confirmatory diagnosis was made even this time, but she had good response of vomiting and pain abdomen to oral steroids. Then she was asymptomatic for 2 months, and the third episode happened in March 2025, again at Max Hospital, with similar episodes of vomiting associated with pain abdomen and no loose stools this time. NG tube was placed. On investigations, all the routines were normal. Even IgE levels were normal. ANA and ENA was negative, and anti-MPO PR3 was also negative. CT whole abdomen with contrast was done, which showed submucosal volodema with mucosal hyperenhancement involving the jejunal and ileal loops along with ascites. So possibility of IBD, that is Crohn's disease, was made based on the CT finding. Push enteroscopy was also done, which showed some non-specific jejunitis. Colonoscopy also showed non-specific ileitis. And the patient complained of some non-specific low back pain, so even MRI SI joints was done, but there was no evidence of sacroiliitis. So on the provisional diagnosis of Crohn's disease, the patient was initiated on IV steroids and azathioprine, but she had no response to this. So she went to another hospital. She was readmitted. The documents are not available for this admission, but she gives history of taking ATT for around 3 days, which she discontinued in view of GI distress. And even on this, the patient did not have any relief, so she came to AIIMS. When she was admitted with Department of Gastro in April, with a similar complaint, NG tube was also done, and the previous CTs were then discussed between the Department of Gastro and Radiology. So now I would like to invite Dr. Neha, Senior Resident from Department of Radiology, to discuss those details.
So good afternoon. We have the contrast enhanced CT from March of this patient, and the axial images we can see that there is diffuse circumferential adimatous wall thickening involving all the jejunal loops as well as the ileum with mucosal hyperenhancement and submucosal edema, and there is moderate ascites. Again, the columnar reformatted image shows very well the circumferential thickening with neural stratification in the jejunum as well as the ileum. The subsequent CT was done 28th of March. On those images, we can see that the jejunal and ileum thickening has actually resolved, and there's just mild thickening in the rectum, and also the ascites has resolved. So, the appearance that we saw, the diffuse circumferential thickening with neural stratification, is known as the target sign, and this is the most common pattern of abnormal bowel wall enhancement. It occurs when mucosa and muscularis show enhancement while there is submucosal edema. And this is actually a very non-specific imaging finding. All we can tell from this is that it's a benign pathology and it is most likely due to bowel wall edema. So it has a very wide range of differential diagnosis. In a case where there is such diffuse involvement, the first differential would actually be infective enterocolitis, which can be due to Shigella, Salmonella, or even in patients who are immunocompromised due to CMV or Cryptococcus. Second is portal hypertension leading to mesenteric venous congestion that can also cause bowel wall edema giving a similar appearance. Mesenteric ischemia can also lead to bowel wall edema, which again would look similar. Inflammatory bowel disease, again, inflammation can also look like this, but the points that against inflammatory bowel disease in this particular case is the diffuse jejunal as well as ileal involvement, with no Crohn's disease would typically have skip areas, would have areas of luminal narrow and stricturing fistulae, none of which are seen in this particular case. Intestinal angioedema is a possibility. Radiation enteritis definitely can look like this, but there has to be the history of radiation exposure. Again, graft versus host disease would be relevant in the appropriate clinical context. Hypoalbuminemia again can lead to bowel wall edema, which may look like this. So basically, on the imaging, we have a wide range of differentials which would have to be narrowed based on further clinical as well as the lab.
Thank you, Dr. Neha, for all your inputs. So based on those DDs discussed, we did, the gastro department did more investigation. So the routines were normal, serum albumin was normal, the autoimmune workup was also done. So ANA and ANCA were negative. However, the C3 levels were low and C4 levels were borderline low. The TSH was normal. All the stool workup was negative for ova, cyst, parasite, cryptococcus. C1 inhibitor levels were also done, which was normal. However, serum chromogranin A levels were elevated. So based on the elevated chromogranin A levels, Dotanok PET scan was performed, which would be discussed by Dr. Hemant from Department of Nuclear Medicine. Dr. Hemant, please.
Good afternoon, everyone. So Dotanok scan was performed in view of increased chromogranin A. So this is the MIP image, the Dotanok scan, which shows the normal physiological pituitary uptake. It is showing the thyroid uptake, which is usually seen in the Dotanok scan, but that is mild. In this case, this is more intense and more diffuse tracer uptake. Other than that, the normal physiological tracer uptake is seen in spleen, in liver, and excretory through the kidneys and the bladder. So in the coronal section, we can see diffuse tracer uptake in the thyroid, that is showing some chronic thyroiditis etiology. Other than that, there is no other focal abnormal lesion in the abdomen region or its body to suggest any SSTR expressing pathology like neuroendocrine tumors. This is the thyroid showing the diffuse tracer uptake. Other than that, there is a diffuse edematous changes in the bowel wall and intestine. This is non-contrast, so we cannot get more further information. But there is no SSTR expression that shows any NET or SSTR expression pathology. Thank you.
Thank you, Dr. Hemant, for your inputs. So as the Dotanok PET was negative, so further investigations were done and capsule endoscopy showed normal study. Upper GI endoscopy and duodenal biopsy revealed duodenal lymphangiectasia. The patient, however, also complained of intermittent dysphagia and constipation. So high-resolution esophageal manometry was done, which revealed absent contractility, and high-resolution anal manometry was also done, which revealed anal hypotension with pelvic floor dyssynergia. Therefore, provisional yes, sir, we'll come further for that. Yes, yes. So the provisional diagnosis of gastrointestinal motility disorder was based on this, and the patient was given steroids and azathioprine was continued at 50 mg OD and discharged on tapering doses of steroids. Whole exome sequencing by NGS was also done for the same, and when the report came, it was normal. Then the patient was sent home, and then she subsequently came in the next month of June 2025 with similar episodes, but loose stools this time, 14 to 16 episodes per day, and there was no history of vomiting. The patient was treated with IV fluids and antibiotics. C3, C4 levels were low again, and CRP was elevated. So rheumatology opinion was taken this time in view of suspected angioedema. When we reviewed the case, the patient had a history of mild facial edema with every episode. However, there was no history of respiratory distress. In the previous episode as well, the patient complained of periorbital edema with swollen lips. The family history was negative. There was some history of irregular menstrual cycles, but there was no association of episodes with those menstrual cycles. So, provisional diagnosis of angioedema with normal C1 inhibitor levels was made and decided to give a trial of 2 units of FFP, and the patient showed drastic improvement overnight in the form of reduced facial swelling and GI symptoms. So the steroids and azathioprine were stopped, and patient was discharged in stable condition, advised to get FFP in any subsequent attacks. Then just 4 days after that discharge, the patient got admitted at Fortis Hospital with similar complaints. 2 units of FFP was transfused, and the patient relieved symptomatically and discharged. Then in July, she came to us and was admitted with similar complaints. Again, 2 units of FFP were transfused. She was relieved symptomatically and discharged within 1 day. Then in September, she again came with complaints of multiple episodes of vomiting and pain abdomen, and ultrasound abdomen was done this time. So as you can see, so extensive involvement of bowel loops along with liver enlarged and bilobar IHBRD along with CBD and portal vein are also dilated with mild to moderate hydronephrosis in bilateral kidneys and mild free fluid in the abdomen. This was done in the emergency, so we don't have the imaging right now. At this time, she required 6 units of FFP along with IV steroids and IV antihistaminics, and she was also started on tablet danazole 50 mg OD. So review ultrasound was done after all this treatment was given, and there was extensive reversal as well. So there was improvement in diffuse thickening of small bowel loops, hydronephrosis was completely resolved, and even CBD and portal vein now showed normal caliber. So she was discharged on prophylactic dose of danazole 50 mg OD. But again, after 10 days, she came after with similar complaints. This time, C3, C4 levels were again low. TFT was repeated, and TSH now was elevated to normal T3 and T4. C1 inhibitor levels were again repeated, but they were normal again. Repeat ANA, ENA was also negative, and ultrasound thyroid was normal. So she was treated with 2 units of FFP, IV steroids, and discharged on danazole and mirtazapine, considering the stress factor which could cause the triggers. And then she was asked to follow up with anti-TPO levels since the TSH was elevated. Then again, just after 10 days, she came with same complaints. C3, C4 were low, and anti-TPO done this time showed very high levels. CT abdomen was done, which showed similar findings as that was in March 2025 with thickening in the jejunal loops, halocine, and minimal interbowel free fluid was also present. She was given 5 units of FFP this time and IV steroids and started on tablet thyroxine 25 microgram a day. However, the patient still did not improve, and she developed multiple episodes of vomiting, which was blood tinged. So we did a CT angiography, but it showed normal study of abdominal arteries, mostly suggesting that the blood tinged vomitus was secondary to repetitive episodes causing ulceration. And there was also same complaint, like same diffuse wall thickening as in the previous CT. However, now it had new involvement of stomach, duodenum, and distal colon as well. Previously, there was only jejunal involvement in the CT on 30th September. So reanalysis of whole exome sequencing by NGS was also sent, this time with the indication of possibility of angioedema, but the report was normal again, making hereditary forms of angioedema less likely. So what can we do now? And why is the frequency of episodes increasing? And how can we treat the ongoing episode which is not even responding to FFP this time? So extensive review of literature was done. Even serum chromogranin A levels were repeated, considering positive last time, but these were normal again. Injection rituximab 500 mg IV infusion was given on 5th October, considering acquired angioedema secondary to immune complex mediated mechanisms causing consumption of complement C3 and C4. The patient improved symptomatically and was discharged on thyroxine and multivitamins, and all other medications were discontinued. Then, now she has presented to us again just 4 days back with presentation of loose stools, 3 episodes in few hours, and she was admitted immediately after that. The patient also developed vomiting just 2 days after admission. C3, C4 levels were low. Ultrasound abdomen showed the same wall thickening in the bowel loops and free fluid. So she was initially given oral antibiotics considering acute gastroenteritis. However, just 2 days after admission, when she developed vomiting, we gave her 2 units of FFP. But the patient only had partial response. So now, the game changer. We were able to get human C1 esterase inhibitor this time, and she was given 500 international units of C1 esterase inhibitor on 26th October. That is just 2 days back, and the patient responded very well within 12 hours. So here we are presenting you this case. Talking about the timeline of the patient, a few things to be considered here. The size of the pink bar represents the duration of the admission the patient had in each episode, showing that how much disease burden and how much quality of life of the patient is getting affected because of these. Secondly, the duration, the frequency of the episodes has also increased, and the duration between 2 episodes has also decreased over time. Thirdly, the patient was misdiagnosed as like so many things before getting the correct diagnosis. Like she was misdiagnosed as Crohn's in March, received azathioprine, misdiagnosed as TB in April, received ATT, then misdiagnosed as gastrointestinal motility disorder before getting the correct diagnosis. Fourthly, as you can see, the requirement of the number of number of units of FFP has also increased over time. So summarizing the case, the patient had recurrent GI symptoms plus facial swelling. There was very good response to human C1 esterase inhibitor and good response to FFP and steroids. So based on all of this, we have made a final diagnosis of acquired angioedema secondary to autoimmune etiology. Now I would like to invite Dr. Sanjay, senior resident from our department, to take up the discussion for the case.
Good afternoon, everyone. I am Dr. Sanjay, Senior Resident, Department of Rheumatology. I will be discussing the discussion of this angioedema, that case we have managed. Angioedema is defined as intermittent, localized, self-limiting swelling of subcutaneous or mucosal tissue due to a temporary increase in vascular permeability. Our understanding of angioedema has evolved over a period of time. Initially, it was that Quincke in 1882 first time gave the term angineurotic edema. It was based on the presumed etiology of neurogenic mechanism behind this disease, and also first time noted the hereditary pattern. But only after a century later, there was discovery of C1 esterase inhibitors, and there was also bradykinin was also identified as a mediator in this disease, which led to our this thinking that it is not a neurogenic rather than it is a vascular mechanism which is leading to angioedema. Angioedema is basically of two types, that mast cell mediated versus bradykinin mediated. This table highlights the basic differences between mast cell mediated and bradykinin mediated angioedema. Mast cell mediated angioedemas are often have an acute onset of a trigger, usually within 1 hour, and last for shorter period of time, whereas bradykinin mediated angioedema have a gradual onset of trigger and last for longer time. And there is no urticaria bradykinin mediated angioedema, but they have predominant pain and abdominal symptoms. Airway movement can occur in both, and additionally, bradykinin mediated angioedema have low complement, particularly this low C4, and there is a C1 esterase inhibitor either dysfunction or deficiency. And this again just a division highlighting the differences between mast cell mediated and bradykinin mediated angioedema. Mast cell mediated angioedema, there is a predominantly histamine release is there from mast cells, which is causing the angioedema. Whereas in a kinase mediated angioedema, there is production of bradykinin. production of bradykinin, which act on B2 receptors and cause the angioedema. Angioedema is classified in various, now it is based on mechanism and underlying etiology. Most common is hereditary angioedema, which is inherited in autosomal dominant manner. Type 1 and type 2 are caused by mutation in certain one gene mutation, which leads to either C1 esterase inhibitor deficiency or dysfunction. And there is also type of hereditary angioedema as described with normal C1 esterase inhibitor function and quantity, and it is most often due to factor 12 mutation, which is gain of function mutation. Acquired angioedema usually occurs in later parts of life, and it can be because of either increased consumption of C1 esterase inhibitors, or there is a formation of autoantibodies against C1 esterase inhibitor. Other types are idiopathic and drug induced, which is most commonly due to that ACE inhibitors. This picture, this slide is showing the underlying pathway involved in hereditary angioedema. There is two pathways are basically involved, that contact or fibrinolytic pathway and classical complement pathway. Contact pathway start with factor 12 activation and leads to formation of bradykinin, which leads to angioedema, and also activated factor 12 leads to the activation of classical complement pathway, which leads to a cascade of complement formation, and these complements also lead to the vasodilation and causing angioedema. Back to our case, our patient has predominantly abdominal symptoms with no urticaria, and episodes were of longer lasting duration. On our evaluation, that C1 esterase inhibitor levels were normal. There was decreased C3 and C4 levels, and patient also had response to steroids, although partial, and has a good response to FFP and C1 esterase inhibitors. So our patient has most likely fitting in bradykinin mediated angioedema, possibly of acquired etiology. This is the newer classification of angioedema, again based on the underlying mechanism which is causing the angioedema. So our patient has been acquired C1 esterase inhibitor deficiency. Now we will be discussing few special scenarios of angioedema, its association with the abdominal symptoms and thyroid disease. Our patient also had predominantly abdominal symptoms. So angioedema can have predominant abdominal symptoms, which most commonly is pain, which can be of varying severity, ranging from acute to chronic recurrent pain, and intensity can be also from mild to severe type. Vomiting and diarrhea are also common presenting manifestation, and due to these common symptoms, patient may go undiagnosed or misdiagnosed for years, receiving inappropriate treatment and unnecessary interventions. It has been also reported that one patient had GI symptoms beginning adolescence, and he was diagnosed with hereditary angioedema at the age of 78 years. But that's why that attacks, but in hereditary angioedema is often misdiagnosed as appendicitis, gastroenteritis, obstruction, IBD. Similar things has also happened to our patient also. But differentiating features can be that these attacks are often frequent, recurrent, and sometimes they can also be that stress factor can also be identified along with this. Now we will be briefly discussing that angioedema and its association with autoimmune thyroid diseases. Autoimmune thyroid disease is observed in patients of angioedema, and it has been found that patients with urticaria and autoimmune thyroid disease have higher incidence of angioedema, and similarly, patient with angioedema also has autoimmune thyroiditis as the single most secondary autoimmune disease. Mechanism in thyroid diseases for angioedemas are there are thyroid peroxidase and other thyroid antigens which can trigger the classical complement pathway by formation of antibodies, and that's why that autoantibodies are often positive and they can act as a marker of antigenicity. And additionally, in hypothyroidism, there is a decreased level of bradykinin, which will also increase the increase the levels of bradykinin, and it will act on B2 receptor, causes angioedema. There have been case reports and series of hypothyroidism with angioedema, where the patient and also the patient with urticaria and angioedema in patient with autoimmune thyroiditis, and even patient with normal thyroid levels but having positive autoantibodies can also have angioedema. It has been reported, and these patients have, even with normal thyroid levels, that angioedema responded with levothyroxine supplement. So again, that angioedema treatment in patients with hypothyroidism, main line of treatment is levothyroxine therapy, but there is dose dependence and relapses often occurs, and rarely refractory cases may even require thyroid. Now we'll briefly discuss the management of bradykinin-mediated angioedema. Like our understanding of disease, the management has also improved over a period of time. Initially, it was just a supportive care, but around 1960, there is discovery of C1 esterase inhibitors, which has led to the drastic improvement in management of patients of angioedema. And later on, we also discovered androgen and antifibrillators. Now we are targeting that targeted path mechanism are under trials. Acute episode is managed by C1 esterase inhibitors, which can be plasma derived or recombinant if available. But in most scenarios, it is expensive and not available easily. So FFP transfusion is also effective. Newer drugs are icabitane, which act on bradykinin B2 receptors, and ecallantide, which act as a kallikrein inhibitors. Patients with angioedema have recurrent symptoms, so they often require prophylaxis. Short-term prophylaxis is considered in patients with expected stress or just as medical procedure or surgeries, which is again if prophylaxis. We commonly use C1 esterase inhibitors, and in minor cases, although that tranexamic acid and danazol can also be used. For long-term prophylaxis in patients with frequent and severe attacks, subcutaneous lenalidomide, which is again targeting kallikrein, and oral barotransferase, which is also kallikrein inhibitors, it has been approved. And again, that most effective will be C1 esterase inhibitors, which can be given by IV or subcutaneous route. Other options are danazol and tranexamic acid. Now there are fewer emerging agents which are not yet approved, but they are under trial, which again targeted the underlying mechanism, that targeting the factor 12 monoclonal antibodies and subcutaneous RNA inhibitors, again pre-kallikrein, which has an important part in development of angioedema. There is also evidence of rituximab-based treatment in angioedema with acquired C1 inhibitor deficiency, in just like our also patient, because that acquired C1 inhibitor deficiency is often immune complexes related, and rituximab has a role in decreasing the immune complex formation. So in multiple studies conducted, it is found that patients receiving rituximab for acquired C1 esterase inhibitor deficiency have less frequent relapses compared to patients who are not receiving rituximab. So take home message will be that angioedema should be considered early in patients with abdominal symptoms and bowel thickening, especially if symptoms are recurrent, and timely diagnosis improve the patient outcome and prevent inappropriate treatment and unnecessary interventions. On behalf of Department of Rheumatology, I would like to extend my gratitude to Department of Gastroenterology and Human Nutrition, Department of Radiodiagnosis and Interventional Radiology, Department of Nuclear Medicine, and Department of Lab Medicine for their support in management of this case. Thank you for your patient listening. Now I invite Dr. Danvir sir for concluding words.
So thank you. Angioedema with normal C1 esterase inhibitor is always a diagnosis of explosion. There should be high index of suspicion to avoid mismanagement, complication, unnecessary intervention and investigation. And at last, don't hesitate to take opinion of rheumatologist if you are in doubt. So rheumatic diseases are multifaceted. I don't know about rheumatologists, but rheumatic diseases are multifaceted. Thank you. Any comment, question? Yeah, Siddharth is there, and we have Dr. Parveen Isaria from Australia. He is head of the clinical immunology and allergy, Royal Adelaide Hospital, Australia. So probably he is on live. He might be able to comment on something. So after that, You can ask. Sir, good evening there, and we are good afternoon. So, thank you, sir. Thank you. So, any comments, sir? So, counselor was not available in India. Yes, the only also we have explored, but that is costing around 9,000 and it is being done once in a month. Allow it. Yes. So, PET scan, the one that still was done, PET scan can be done. So, Siddharth is asking something, I think the director department.
Second thing is NCS, correct? NCS patients, hereditary versus acquired. Third thing is ruling on
Yeah, we are running late, so thank you, sir. Thank you so much. We will get back to you with the extent. Yeah, fine.
So you saw how difficult sometimes it is to get to the right diagnosis. Our patients with autoimmune diseases, they do respond with immunosuppressants and steroids. Even we don't know what it is, so it becomes all the more important to get to the root of the cause and treat it. Thank you so much for it. And sorry for encroaching upon your time.